here. I'm delighted to see all of you here. I'm Brian Shute. I'm a speech-language pathologist here in town. I've seen a fair amount of laryngectomies over a couple, 3 decades. And this whole business of laryngectomy started in 1873. There was a physician named Theodore Billroth. He was in Vienna, and he came across a 36-year-old gentleman who was a school teacher who had a subglottic tumor, and he decided he needed to get that thing removed. Now, Billroth, his first love was music, so he had a great deal of knowledge of the viola and musical reeds. He worked with an instrument maker to create basically the first artificial larynx, and it was made up of a cannula and a reed system. And it did provide this man with some intelligible speech, and during that time, there was a lot of debate over laryngectomy to begin with. It was a pretty radical surgery back then, as you can imagine, without antibiotics, without the present-day medical type things that we have now. That was quite the endeavor to be doing that. In fact, if you ever get a chance to read the manuscript, the surgical report, it's fascinating to read. But it spurred a lot of debate back then as to whether or not laryngectomy should even be done. After all, it was creating a certain amount of disfigurement on the neck. It was impairing communication. For a certain amount of folks, the cancer was returning. So back and forth, there was a lot of debate. Now, Billroth's techniques changed over the years, although some of those things are still in practice today. But it gives you an idea that communication after laryngectomy is very important. It was important then, and it's really important now. So, many of you, as kids, used to inhale helium, I can tell. And interestingly enough, these cats have done the same thing, except it had a little different effect. The helium, when it's brought into the lungs and airway, it actually changes the travel of sound. And sound travels differently, resonance travels differently. The vocal cords vibrate differently when helium is present. So that's why you get that squeaky kind of voice when inhaling helium. Now these cats, they actually float. Okay, for sound to occur, there are some basic things that are needed. When you're looking at the human sound tract, you need lungs, which act as the power source. And when you are looking at the normal individual, the vocal cords are providing the vibration source. And then you need articulators, you need your resonators. Your articulators include the mandible, the teeth, tongue, lips, your soft palate. And the resonators are the oropharynx, nasopharynx, the actual head. Now you can tell that this individual, like Dr. Mitchell spoke, let's see, air is taken in through the nose and through the mouth, and it travels down back behind the tongue, down the airway, through the vocal tract, down into the lungs. That air that is down into the lungs is used to move up the vocal tract and vibrate 2 cords, the vocal folds. That creation of sound is more of a buzz than anything. In fact, if I could unscrew your head and lift it up and place it on the table and look down and say, give me an ah, it would be more of a ah sound, more of a buzzing kind of sound. But it's that sound that enters into the vocal tract, into the head, and into the mouth that provides us with articulation and speech as we know it. So, there are some changes that occur after an individual has had a laryngectomy surgery. And these folks are basically replumbed. Everything else is pretty much the same, other than the airway. So when you're looking at a laryngectomy, the presence of the tracheostoma is going to be key. There's going to be a mature, healed tracheostoma present. That's going to be at the base of the neck. These folks have no larynx, they have no vocal cords, so they are simply missing the sound source. The vibrating vocal cords are no longer there, but the articulators, the tongue, the lips, the teeth, all that is in place. So they can still articulate speech if they had a sound source. So when you're looking at a laryngectomy, you're going to notice that the neck is flat along the front, and it's going to be a fourth, maybe a third smaller than a normal neck. And when you're looking at a laryngectomy, oftentimes you'll notice that it seems that the head is a little larger and the neck is a little smaller. And you will notice that the symmetry is changed from a normal individual. And like Susan mentioned, with the larynx gone, you're going to see these two ridges oftentimes alongside where the Adam's apple would be located. So a laryngectomy is going to have a different looking neck. The front of it is going to be flattened. It's going to be smaller. There's going to be a tracheostoma present. And there's going to be what I like to call neck gear. Okay, what's neck gear? Neck gear is a bunch of different things that can cover the tracheostoma, that can be in the tracheostoma, can be around the tracheostoma. And this gentleman is a pretty good example. And you'll notice that he's got what's called a cloth cover or a cloth tracheostoma cover. He's got the housing that's actually glued onto his neck. Underneath the housing, there is a TEP or a tracheoesophageal puncture prosthesis that's in place. You can see that right dead in the center. You can see the little tab that raises up, which, by the way, is underneath that glued-on donut that you see there. For many laryngectomies, many that you'll see here today, there will be a cassette located right in that hole that plugs into that hole that actually provides humidity and moisture and warmth as they breathe. So there's all sorts of things that can be in the tracheostoma. And stoma buttons are one of those things too. It's a plastic button that maintains the diameter of the tracheostoma. And it's just a simple plastic piece. Sometimes they're made out of silicone or rubber that fit in there. Stenosis is a common thing. The tracheostoma oftentimes wants to close up. So the stoma button or stent, those kinds of things keep the tracheostoma actually open. So you can see that there's just all sorts of things that might be present there. But the same general whole you're going to see over and over again. Regardless of the stuff that's glued on it or surrounding it, there's going to be that mature tracheostoma. Now, a good filtering device actually does 4 different things. It covers the tracheostoma, which is a pretty personal kind of hole. It keeps debris, dust, dirt, that kind of thing out of the lungs, out of the tracheostoma. It warms the tracheostoma. The nose actually is a terrific humidifier, and as a person is breathing in, air is warmed before it hits the lungs and provides a certain amount of humidity into the airway. And then also, it provides just moisture, lots of moisture. So it's important to have some kind of covering. Now, what happens a lot of the time when people don't have some kind of covering system over their tracheostoma is those crusts that Dr. Mitchell talked about, those start to form. And that comes from dry air hitting that mucus and solidifying it and making it very, very solid. So laryngectomies are instructed typically to have that cassette in place or to have some kind of filtering cover, whether it be cloth or perhaps a foam tracheostoma like this. I'll pass some of these things around. Some of those kinds of things are just really important for laryngectomies. And a lot of people don't really realize the importance of those kinds of things. But you may come across in the field somebody that has no gear on, just an open stoma. You might find somebody that has a simple foam pad. Maybe they have a filter cover over their tracheostoma, or a plug-in cassette that acts as the filter. Okay, so you're going to come across generally three different methods for communication. The artificial larynx, also known as the voice aid or electrolarynx. Sometimes you'll hear people talk about them as speakers or my little voice box, those kinds of things. Sometimes they're called buzzers. There are all these kind of lay terms that people will assign their artificial larynx devices. Esophageal speech is another technique, and tracheoesophageal prosthesis is yet another. So 99% of folks that have been laryngectomized are going to use one of these three techniques. So let me start with the artificial larynx. This is a device that electronically or pneumatically creates a signal. It delivers that signal either through the outside of the neck or the cheek, or it pneumatically delivers that signal directly into the mouth. So I brought some examples. This is a neck-type device. It's, 4.5 inches long. Uses a little battery like this, and it provides a tone like this. You can hear that buzz, but it's a very focused tone and it's very strong. So it penetrates through the neck and allows a person to articulate. So if I hold this thing to my neck firmly,
are you able to understand me? Yes. What this device is doing
is providing a signal that goes in through my neck, and it's just simply replacing what the vocal cords used to do. So it's just providing that sound source, that vibrating source. Okay, so there's a whole bunch of different kinds of these. Most of them all use a battery. This is another one that actually has intonation. So a person can intonate.
Hello, how are you? Are you able to understand me?
You can hear how my pitch is going up and down. In fact, you can even sing with this. Something like that. So these are neck-type artificial larynx devices, and these are probably the most prevalent devices that you'll see, neck-type, that category. And they sound the best. You can hear, you were able to hear my voice, you were able to understand me, it has a lot of carrying power. Now, the other category is intraoral devices, and some of these can be simply turned into an intraoral device by putting an intraoral adapter on top. See what I'm doing? The tone is being delivered inside my mouth via a little tube. And I'm just articulating the sounds just like I normally would. And the sound source is being presented just directly inside my mouth. Now I mentioned a moment ago that some are pneumatic. So here's a pneumatic artificial larynx. And this device would actually go over the tracheostoma. This little tube would go in the mouth. And when the patient expels air through the tracheostoma, see, it provides a tone that allows the person to articulate intelligible speech. So, under the category of intraoral type devices, there is I'll call it a subcategory called denture type. And every once in a great while, maybe you'll find somebody with this. They're very rare, and they don't work very well. And basically what these devices are an upper plate which have electronics housed in the upper plate with a battery. So a patient takes the thing out, they plug it in, they charge it with the battery, they put it in, and the idea is that with a little remote control, you can turn the thing on and you can intonate some speech with the device. The problem clinically that I've seen with those, and I think one of the main reasons why they're not real successful, is the electronics need to be housed in such a huge denture type device. So the tongue doesn't have a lot of room to hit those articulatory targets inside of the mouth to allow you to articulate good speech. But it's out there, and sometimes you will run across. In fact, years ago, just historically, there was a device, it was called the Speech Master, and it was a denture type device that had a sound generator inside of it, and you would use your tongue to click it on, and you use your tongue to click it off. And of course that poses kind of some interesting communicative problems, because you got to be using your tongue to turn it on and turn it off. And anyway, it wasn't successful, and you don't see it around much anymore. You don't see it at all anymore. Okay, so greater than 95% of folks can use an artificial larynx. They're easy to learn, they're functional, they're powerful, they're robust, and they provide great service for a lot of laryngectomies. They do require the device itself, of course, and batteries, and you need to have one hand to operate the device as a general rule. One manufacturer has a kind of a platform that fits on the chest that allows you to move your chin down or in a position where it'll click the switch and deliver the tone on the neck. You don't see very many of those kinds of things out there. Okay, so esophageal speech. Now, once upon a time, this used to be considered the gold standard of alaryngeal communication. So if you were a laryngectomy, by golly, you were going to learn esophageal speech. But there's a problem with that. I'll get to that in just a second. Now, esophageal speech is a technique where air is injected into the upper esophagus and it is squeezed out for speech. So air goes in, kind of fills up the upper esophagus, squeezed out for speech. So what's happening is an anatomical structure called the pharyngeal esophageal segment is actually vibrating, and we refer to that as the PE segment. So it's like a burpy kind of quality. Air's going in, it's inflating the upper esophagus. I'm using that to vibrate the PE segment. I'm putting more air in. It's like money put in a bank account. You put the money in, you take it out, put the money in. And it sounds like this.
Hello. How are you? Are you able to understand me?
Esophageal speech. Okay, so 40 to 60% of anybody, laryngectomy or not, can actually learn or have the ability to learn esophageal speech. It's definitely not for everybody. And historically, just a great disservice was done to a lot of laryngectomies where, some of the early artificial larynx devices that were out on the market back in the teens and the 20s even, there was this notion that if you couldn't learn esophageal speech, by golly, you were lazy and just weren't trying hard enough, and no, we're not going to give you an artificial larynx because you have to learn esophageal speech, by golly. And of course, a lot of laryngectomies were squelched because of that. They really needed some other kind of system because not everybody can acquire a functional esophageal speech. Okay, so those that do, it's got some pros and it's got its cons. It's a no equipment type system, so you don't have to have anything to use it. It's hands-free. It's really inexpensive. It does need some training, and you could tell when I was giving you a little sample there, the rate of my speech was slow. It wasn't as fast, and it was softer in volume. And the problem with people acquiring it is that PE segment really needs to be able to vibrate. And for some folks, when you get air past that PE segment, it wants to squeeze up or spasm. So air doesn't move past it. And of course, there's no vibration and no speech. So that is an offering for esophageal speech. Now, we go to tracheoesophageal puncture speech, and this is something that you see a lot more of. In the last 20 years, 25 years, it's grown tremendously. But this method uses a small silicone one-way valve, and it's placed in the puncture. It's placed in a puncture that's surgically created, and that puncture is between the back of the tracheostoma and into the esophagus. So pulmonary air from the lungs moves passes through the prosthesis and into the esophagus where the PE segment vibrates. And I refer to it as turbocharged esophageal speech. So with esophageal speech, you can get a fairly small amount of air into the upper esophagus. And you could tell when I was giving you the example, it's very limited. But with this, when everything's working great, you have the benefit of the lungs. And there's a tremendous amount of air that can power that PE segment and allow for vibration and that sound source. So oftentimes you'll find that it's louder, it's quicker, those kinds of things. It's very common now. You see a lot of people around with them, and it's really interesting. Over the years, I've noticed how that whole thing has changed, where there's just a tremendous amount of folks now that have TEP devices. It can be placed on a primary level or a secondary level. So primary, referring to at the time of the initial laryngectomy surgery, the device is placed at that point, or at least the puncture is provided at that point. Usually it's used for a feeding tube while the patient heals, and then later the feeding tube, of course, is removed, and the prosthesis can be placed inside that fistula. There are two general types, patient placed and clinician placed. The clinician placed ones are oftentimes referred to as indwelling, and the difference between the two, this is a patient replaceable one right here, and in fact, actually, just pass that around. You can see that it's got a flange where the one part of the flange is actually fitting inside the esophagus. The other one is at the frontmost portion of the front wall of the tracheostoma. So it's actually a one-way valve. So when a patient has air in their lungs, they use their finger to occlude the tracheostoma, or they put their hand on a cassette, which acts as a valve, and it reroutes the air from the lungs into the esophagus for vibration of that PE segment, and allows for esophageal speech that's much louder because it's being powered by the lungs. Now, the indwelling types usually have a larger collar on the esophagus side and often on the tracheostoma side, and those are placed by the physician or the speech pathologist. So not everybody is a candidate for that. 77 to 92% of folks find success with the tracheoesophageal puncture device. So if you look at some of the pros and cons, it tends to have the most natural sound quality, although sound quality is on a continuum, so you have folks that are really great sounding, and then you have some folks that aren't so great sounding with the device, and then everything kind of in between. It tends to be louder. You get one finger sorry about that. Let's see if I can. So, one finger to occlude the tracheostoma or to press the valve. Although there are some hands-free valves that can be glued in place, and for the right candidate, they work really well. Some folks have problems with the seals blowing out on the neck with those devices, those hands-free type devices. Let's see, tissue health plays a part as to the success of those. Folks with, COPD, emphysema, and some real issues with their lungs might have troubles using that device. Let's see, the stoma size. If the stoma is really small, it might not be big enough to accommodate a TEP device. And, there was the comment about stoma size, and some of the stomas being large and small, and some of them wanting to become smaller. If you have somebody who is very large, let's say a large male, and they've got a tracheostoma that is like a pencil, it's very possible that they're able to breathe okay at rest, but during some kind of physical activity where there is exertion and they require more oxygen, that little tiny stoma might not cut it. So every once in a while we run across those kinds of folks where the tracheostoma is real small and they need to be sent to the surgeon to reevaluate the size of that thing. So they might do okay at rest, but climbing up the stairs at home might create an issue because there's such a restriction there of air. Candida yeast is a big problem really for tracheoesophageal puncture devices. And Candida is a little yeast that tends to grow on the device, and it's like a barnacle. It tends to glue on there, and it will fail the one-way valve. And you got to remember that the TEP is actually a one-way valve that allows air to go in, but doesn't allow foods and liquids from the esophageal side to leak out. And one of the symptoms of a device that needs to be replaced is leakage of fluids, especially into the tracheostoma. And a lot of the time it's because those little barnacles are failing the device. So there are some strategies that are in place to help rid the Candida from growing, and it's different on different people. Some people have a real issue with this Candida growing, and it grows fast, and then other people will just sail along without any trouble at all. So there's really a continuum for that too. So dexterity, being able to get up to the device to occlude it. If it's a patient changeable device, to change it. If a patient's vision isn't good, it's going to cause issues using that device. And if cognitive function is not good, it can pose problems using that device too. There are some ongoing costs of it, and insurance companies, some are better than others about reimbursing for those kinds of things. It does take some upkeep and cleaning. Leakage problems like I discussed. And if it's placed on a secondary level, it's another little surgery that needs to be done to create that fistula for the device. Okay, so in the literature, oftentimes you will hear that laryngectomies have options, that they have a choice. Options implies that there's a choice. And really, you can't assume that all laryngectomies are going to be able to have a choice in what kind of speaking device they use. So there are different things that enter into that equation: the extent of the surgery, physiology, cognitive function, vision dexterity, and resources to keep the device in place and to replace it as necessary. Those kinds of things enter into the picture. So, the three different areas, three different methods for alaryngeal communication of the artificial larynx: TEP and esophageal speech. That's going to make up the vast majority of people, and they're communicating after having a laryngectomy. Okay, so then you start seeing some kind of rare things out there, and this is one of them. This is a TTY device, and basically what it allows a user to do is communicate with somebody else that's got a TTY device, and they type in information, and on the other side is hooked to the telephone. The modem fits in the top portion. The person types, and the individual on the other side who's got a TTY device sees the printout or the display on their device. And there's also something called relay operators. Have you ever heard of the relay operators? So let's say I have this device and I want to call Susan. I can't speak, but Susan speaks and listens just fine. So I would call the TTY operator, and I type in, "Hello, my name is Brian Schutt, and I need to call Susan Brewer at 509, blah, 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 blah." So that the operator, the relay operator, will call up Susan, and she'll say, or he'll say, "I've got Brian Schutt on the other side, and he needs to, or this is so-and-so from the relay operator, and I've got Brian Schutt on the other side, and he needs to contact you or communicate with you." And so it goes like that. So you got an able speaking relay operator who's conveying the message. And oftentimes the laryngectomy, of course, there's nothing wrong with their ears, so they can hear what, say, Susan would be saying, but I would be responding by typing in this device. Will you see a lot of laryngectomies using this? Not a lot. No. Okay, so then there's this other area of devices, speech generating and text-to-speech devices. And as a general rule, you'll see people maybe with cerebral palsy or ALS or some of those kinds of disease processes using this kind of equipment. Very rarely will you see laryngectomies using it, but there are occasionally some that do. So speech-generating devices produce a pre-recorded electronic message corresponding to a button push. So, for example, I've got a device, it's got icons on the front. I push icon number 1 and it says, "Hello, my name is Brian Schutt." I press icon number 2 and it says, "I live at 32 Oak Street." And so on. And some of these get very complex with tiers and levels, and you can get quite a bit of communication into one of these devices. The text-to-speech type things allow a person to type a message and push a button, and it will spit out what has been typed in the device. So I might type, hello, my name is Brian Chuth. Push the button. Hello, my name is Brian Chuth. Like so. And it's a way to communicate. And there's a ton of these kinds of devices out there. And they range from under $100 to thousands of dollars for some of them. And a lot of them are free and available on your iPhones and your Androids. And even if you go to the accessibility part of your computer, you can get some of this text-to-speech stuff. It's just all real available. And you will find some folks that actually use that kind of stuff. But there again, pretty rare. Okay, so then pointing, graphic and written systems, you know, especially right after a person's had surgery, you'll tend to see some of these kinds of things. Communication board might be just a piece of paper that has a picture of a bathroom and a picture of family members or a picture of whatever. And the individual simply points to those kinds of things to convey their needs. Travel companions, that's kind of a neat little deal, and maybe some of you have seen them. You know, just a simple card, maybe front and back, maybe a little cardboard booklet kind of thing, and all it has is just pictures. Just picture, just tons of these pictures. And the idea is that if I want to convey something, I just hold the card and point to the given picture. Paper and pencil, very common. You know, you'll see somebody, especially right after they've had their surgery, using paper and pencil to write messages. A magnet-doodle is like a magnet writing device where you can write a message and then move a slider and it erases it. And dry erase boards, chalkboards, those kinds of things. You'll come across those. A seasoned laryngectomy or you know, one that's received therapy especially generally isn't going to be using these kinds of things. And anytime you take away speech, communication drops way down in efficiency. So if I have to convey messages to you by writing or pointing, those kinds of things, the efficiency of communication is low. And it's hard for the user and it's hard for the listener to use those kinds of systems, at least for a long period of time. In the interim, maybe okay, but if you have to use them for extended time, it's really inefficient. And then, of course, there are literacy concerns too. So if a person that can't read or write, they're going to have real issues using these kinds of things. Oh, nonverbals, this is my favorite. Clicks and chirps, you know, oftentimes a laryngectomy, even though they don't have the airway connected to their upper mouth and nose to their lungs, they can still make a great deal of sounds. See, I could blow out all my air and still make those kinds of things. Clicks. In fact, there's still a lot of sounds that an individual can make, even though they've had a laryngectomy, and even though there's no mechanism between or airway between the mouth and the lungs, they can still make the K sound, and the P sound, and the SH, and a whole host of different sounds. In fact, when you're training with an artificial larynx or esophageal speech, you train those sounds too, so they sound more intelligible and more normal sounding. But clicks and chirps, you know, you can have systems for yes and no. You know, maybe one click for no, and maybe two clicks for yes. And what I would caution you is that if you're using those kinds of systems, you have to pre-arrange with the person that you're using it with to make sure that their system is the same as yours, because you can run into trouble if there's some confusion involved, cognitive kinds of issues, those kinds of things. And then of course gestures and facial expressions, that's going to show you and tell you a lot. You know, if they're pointing to their tracheostoma, you know, maybe there's something going on in the tracheostoma like a mucus plug. And of course facial expressions for happiness, sadness, you know, all those kinds of things, pain. You folks clue into that stuff all the time, I'm sure. Okay, so window stickers and ID cards. You know, these come in all sorts of colors. They're usually kind of bright neon. Oftentimes they're a little taller than a front pocket, so they kind of stop, you know, can kind of pop out of the pocket like so. They all say emergency on the front. Do all laryngectomies have these in their pocket? No. Do some? Yes, they do. Sometimes you'll find these in a purse or a front pocket, and it explains resuscitation type things and that the individual has a neck breather. Medical alert bracelets and necklaces. A lot of laryngectomies have those kinds of things. They're encouraged to get them, and simply looking at the wrist, looking for a pendant around the neck can provide some great information and tell you right away whether somebody is a neck breather or not. And oftentimes that's all it'll say, neck breather. And that clues you in that, well, gosh, that tracheostoma right there really is for a laryngectomy. And then family and friends, if there are family and friends present, they're going to be able to give you all sorts of information. Yeah, my dad has a laryngectomy, he breathes through the tracheostoma, his speaker's over there, but he can't use it, he's having issues, those kinds of things. So talking to friends and family that are around can provide you with a lot of information. Okay, sometimes the laryngectomy can't talk, and they're not in a situation where they can convey information to you. Maybe they're unconscious, those kinds of things. And I'm certain that many of you are familiar with the POLST form. That's the physician's orders for life-sustaining treatment. And it's usually a bright pink or a bright green. I think in the state of Washington it's typically green. And what it tells people is whether you are to be resuscitated or not, what kind of nutrition, you can pass it on, you need, those kinds of things. And so it lets the emergency person know pretty quick, just at a glance, what kind of interventions are necessary, if any. I think it also covers antibiotics and maybe nutrition kinds of things. Sometimes you will find that on the front of a refrigerator, maybe on the closet door, on the inside of a closet door, maybe on a bedroom door. So if you find yourself going into somebody's home or maybe into a nursing type facility or retirement home, those might be some places where you would find that. And you can see quickly at a glance what should be done and maybe what should not be done. Advanced directives, you know, all the hospitals I think have those. They are a pre-arranged set of guidelines that allow a person to communicate their wishes if they are unconscious or perhaps if they have a terminal type condition. They're also known as a living will. And sometimes you will find a advanced directive or living will with the POLST form. So you can look for that as well. Usually there's a spot where the individual can complete a questionnaire providing individuals with their feelings about what kind of care they want. So maybe there's a rating scale. Do you want to be resuscitated? 5 yes, 1 no, you know, and then everything in between. So it allows individuals to provide that kind of information in the case of an emergency. Oftentimes there's a durable power of attorney form in there. And people, just generally, laryngectomized or not, we should really complete one of these things and have it available, just in case. This picture right here was taken at our farm a couple weeks ago. Right after a tremendous downpour, there was this wonderful rainbow that, and this picture does no justice to the view. I mean, it was just absolutely incredible. In fact, I was tempted to go with my shovel and start digging at the end of that thing. It was almost like you could go out there and touch it. But my thought is that communication takes lots of different forms. Three things that you can remember is that there's going to be three general methods of communication that a laryngectomy is going to be using: esophageal speech, artificial larynx speech, or TEP. TEP is very, very popular right now. And by looking at some of the clues that are available to you, the tracheostoma, the neck gear, the flattened neck, those kinds of things, that's going to give you great information as to whether or not that individual right in front of you is a laryngectomized person, whether they can tell you or perhaps not. Any questions?